Thank you, Monica. Now I request the chairpersons of the next session to join and chair the next session. Dr. Lakshmikant Marda, qualifications MD, practicing since last 29 years in rural Western Maharashtra. I had participated and attended many national and international conferences. His area of interest is towards improvement of rural OBGY care to rural patients in rural setup. Dr. Anuradha Garat, past President Usmanabad OBGY Society, Chairperson's Mission Pink Health Usmanabad, faculty in AMOX AICUGO conference, delivered lectures on adolescent health, radio interviews on breastfeeding, cervical cancer vaccination and adolescent health. Conducted camps for cervical cancer diagnosis, pap smear and colposcopy camps in association with Barshi Cancer Hospital. Dr. Lalita Swami, Director Swami Hospital Usmanabad since 15 years, consultant at Swami Hospital Usmanabad since 15 years, worked as medical officer at PHC for 7 years, conducted all national programs and 200 to 300 tubectomy camps, worked as medical officer at Civil Hospital Usmanabad for 15 years. Thank you.
I would request Dr. Rohini Deshpande Madam and Dr. Vidya Tirankar Madam to please join us on the stage as the moderators for this debate session. Both of them are very senior gynecologists of Solapur OBGY Society. And ma'am, we could not have a better judge than both of you to judge the debate by none other than Dabade sir and Sudesh Doshi sir. I request the chairpersons to please introduce our first set for the debate. The topic is double marker for all. So first presenter is Dr. Rajiv Dabade sir.
Dr. Rajiv Dabade is Assistant Professor, Department of OBGY, Ashwini Rural Medical College, Kumbari. He has so many research. Shirodkar sling, a conservative surgery for prolapse, Amox Solapur 1989, diagnostic laparoscopy in evaluation of abdominal tuberculosis, Foxy 2001, learning safe endoscopic hysterectomy, MRCOG Latur 2003, safe entry into peritoneal cavity, Amox Amravati, co-author, poster of India contribution to gynecologist, Figo Washington, forceps versus vacuum, Amox 1992 mirrors, embryo reduction, Abun, MRCOG, Usmanabad, poster on low dose magnesium sulfate, Foxy, New Delhi, poster on mucocolpus at Navi Mumbai. Dabade sir.
Respected chairpersons.
Yes, welcome Dr. Dabade.
Yeah. I have been given a very interesting topic as to whether double marker should be done or not. I think my debate ends with one single statement. It should be done, that's it. But still Sudesh said, where is Sudesh? Yeah. He said that he wants to debate with me because he says double marker is not necessary. Now before I argue with him on certain points, I'd like to enlighten him on the knowledge of what this double marker is. Okay. Two markers, free beta ECG and PAPI. And you may think we should be screening only the high-risk population. What if we screen only the high-risk population, say maternal age more than 35 years? If we can see in this graph, of all the live births born, 87% are born to women less than 35 years of age. Mind well, Sudesh, every slide is important for you. And 55% Down syndrome occur in women less than 35 years. So there is nothing like high-risk screening. It has to be universal screening. We all know, Sudesh, hope you know this. These are the different screening methods. We take into consideration age, PAPA, beta ECG, nuchal translucency, nasal bone, ductus venosus, tricuspid degradation, and now NIPS. Screening test has to be with high sensitivity, though it may also have some false positive rates, because once we screen and we find that this particular case is at high risk, then we go ahead with diagnostic tests because they are highly accurate and on which the management and clinical decisions can be made. So screening tests should be applicable to the population at a large. You cannot restrict it to only the affluent people. Increase NT, the most simplest form of screening. But mind well, this increased NT may mean either it is trisomy 21, trisomy 18, trisomy 13, and as Dr. Raju Sahita just said, it doesn't mean anything, it could be normal too. The individual could be normal too. So what is the beta HCG? It's produced by the placenta. It exponentially rises during pregnancy, you all know that, but its level stabilizes after 20 weeks. And it's high, the levels are high in patients with trisomy 21, I mean the babies to be born, and low in trisomy 13 and 18. This pregnancy-activated plasma protein, again secreted by the placenta, it is necessary for the normal development of the fetus. It increases bioavailability of IGF-1 and 2, and its synthesis is upregulated by progesterone, probably the reason how progesterone works. Low levels are found in pregnancies with adverse outcome. Low levels may also be ectopic, but only in 67% you will find low levels, so that's not used as a test to diagnose ectopic pregnancies. And yes, all IVF pregnancies, these levels are low because they are gonadotropin induced. Why I am stressing this point? Because when we send these double markers, the lab has to get the information how the conception took place. Okay. And the levels are also high in patients with placenta accreta. Now, different screening methods, we use biophysical methods and biochemical methods. We all are aware of this. Nuchal translucency, nasal bone, ductus venosus, tricuspid degradation, biochemical free beta HCG and PAP-A, and the timing of this test should be between 11 to 13 weeks, 5 days. But just to add to your information, these chemical biomarkers work well when done at earlier gestation, say at 10 to 11 weeks. So at 10 to 11 weeks, we should be getting this free beta HCG and PAP-A. Keep the report with you closed, don't look at it. Screen the patient on ultrasound between 11 to 13 weeks, 5 days, and then correlate this. It's important that laboratory should be informed all about the ethnicity of the patient, the weight of the patient, the age of the patient, the type of conception the patient has, whether it's a multiple pregnancy or not, again the roles become problematic, and whether one of the fetus in twins is alive or not. So many things need to be informed to the laboratory. We all must thank this gentleman, and he says that if you take into consideration only age, you are going to be correct only 30% of the times as far as the anomaly in the fetus is concerned. If you add free beta HCG and PAP to the age, this incidence increases 60%. So I mean, you will be accurate 60% of the times, though you will be wrong 40% of the times. You add age and NT 80% of the times. You add age plus nuchal translucency plus free beta HCG plus PAP-A 90% of the times. And to above this all, you add DV and nasal bone and tricuspid, you are accurate 95% of the times. And NIPS, yes, 98% of the times. But then the question of affordability comes into play. Now just one point I wanted to highlight here, because nuchal translucency is to be done by a specialist in fetal medicine. Okay, those who have that certificate from Fetal Medicine Foundation. May not be possible in places like Pandharpur, okay, where you practice. But at least get this dual marker done, so that at least 60% of the times you are right. Just have a look at what we are looking for. We are concerned about the baby having Downs or Edward or Patel. Most of the times we talk about Downs. Okay. What about trisomy 18 and 13? We talk about Downs because the incidence is 1 in 500 pregnancies. Edward will be, incidence will be 1 in 6,000. And Patel will be, incidence will be 1 in 12,000 pregnancies. That's why we talk more about the Downs. Now let's see little differences between these three syndromes. All of them have low intelligence quotient. Okay, Downs and Patel will have congenital heart diseases, and Edward lands into IUGR. Downs are at risk of leukemia. Edward and Patel, Edward is at risk of IUGR and hence IUFD also. there is increased incidence of neural tube defects in trisomy 13. Downs die young, but trisomy 18 and 13, there is a chance of neonatal death. They may not see the first year of their life. So question of double marker was NT. When done without double markers, NT alone is less effective. I know, Sudesh, you are staying in Pandharpur and everything happens with the blessings of this Almighty. But if you only depend upon the blessings of this Almighty, you know what happens. So this gentleman also went to have the blessings, but he did not forget the 2 remaining markers. Okay. That took him to the success. This is the picture we had when we visited your hospital. I am sure, looking at the hospital, anybody can say, the elite people from Pandharpur must be visiting Dr. Sudesh Nursing Home, because they know you are going to give them the best of the treatment even in Pandharpur. And then if you eliminate dual marker test, I am afraid what's going to happen to your hospital. Okay. Thank you very much, gentlemen. Thank you, chairpersons.
Thank you. It was very enlightening. Welcome, Dr. Sudesh.
नमस्कार. या सभागृहात बसलेल्या सगळ्या तेजपुंज व्यक्तिमत्वांना माझा नमस्कार. दबडे सरांना मी गुरुस्थानी मानतो, त्यामुळे मी त्यांना प्रतिस्पर्धी किंवा प्रतिद्वंद्वी मानत नाही. मी फक्त प्रतिवादी मानतो. इथं थोडासा वकील असल्यामुळे थोडं वादविवाद पण करता येतो. तर याच्यामध्ये मी थोडंसं मराठीचं पण आधार घेतलं. मला वाटतं डिबेटमध्ये ते चालतं आहे. नाही, इथं सोलापुरात पण चालतं. तर विषय असा होता, डबल मार्कर फॉर ऑल. नुसतं डबल मार्कर नाही, नुसतं डबल मार्करला माझा विरोध नाही. डबल मार्कर करायचं, पण सर्वांसाठी करायचं का नाही? नाही, नो. वाय? नेक्स्ट स्लाइड. अच्छा, ठीक आहे. एखादी आपल्याला टेस्ट करायची असेल तर त्याच्यामध्ये ह्या सगळ्या गुणवत्ता असल्या पाहिजेत. आकुडशिंगी बहुदुधी जसं म्हणतो आपण त्याप्रमाणे. इट शुड बी रिलायबल, विश्वासार्थ असली पाहिजे, ॲक्युरेट, अचूक असली पाहिजे, अफोर्डेबल, परवडली पाहिजे, अवेलेबल, इथं हजर असली पाहिजे, ॲक्सेसेबल, आपल्याला त्याच्यापर्यंत पोचता आलं पाहिजे, इंटरप्रिटेशन नीट वाचता आली पाहिजे. मला खरंच तुमच्या ज्ञानाविषयी शंका नाही, पण तो डबल मार्कर टेस्टचा रिपोर्ट सगळा किती लोक वाचतात आणि नक्की त्याचा अर्थ सगळ्या पेशंटला किती लोक समजावून सांगतात हे थोडंसं अवघड असतं. बऱ्याच वेळेला कन्फ्यूज होतं. इंटरमिडिएट रिस्क आली, बंडू म्हणतो इंटरमिडिएट मला फोन करतो, अरे सुदेश ती इंटरमिडिएट रिस्क आली म्हणजे नक्की काय असतं रे? मी म्हणतो दबडे सरांना विचार, मला येत नाही. आणि इट शुड बी ॲक्सेप्टेड अँड रिकमेंडेड बाय गव्हर्नमेंट अँड अपेक्स बॉडीज ऑफ द लाईक फॉक्सी. तिरणकर मॅडम म्हणतात आमच्या सिव्हिल हॉस्पिटलमध्ये नाही डबल मार्कर वगैरे काही नसतं, अवेलेबल नसतं, आमच्या पेशंटला परवडत नाही. मग जे पेशंटला परवडत नाही तर फक्त इलिट लोकांना का द्यायचं? ती काय लाडकी बहीण थोडीच आहे, फक्त 1500 बाकीच्याला द्यायला नाही, सगळ्याला मिळतं, बाकीच्याला नाही मिळत. आणि फॉक्सीने सुद्धा रेकमेंड केलं पाहिजे. तर आता बघून रिलायबिलिटी असिस्ट इन टर्म्स ऑफ सेन्सिटिव्हिटी अँड स्पेसिफिसिटी, त्याची संवेदनशीलता आणि अचूकता किती आपल्याला बघायचं आहे. NIPTला 99%. मग NIPT सारखे टेस्ट असावे, NIPS सारखे टेस्ट जे त्याचं उत्तर हो किंवा नाही असं देईल, असं होण्याची शक्यता आहे. आणि ती शक्यता जास्त असेल तुम्हाला अजून एकदा पोटात सुई घालून पाणी काढावं लागलं, 15,000 रुपये देऊन तपासून आणावं लागेल. आणि ते पाणी तपासायला सोलापूरला जावं लागेल. सोलापुरात गेलं तर सुमित म्हणतो सकाळी 8 संध्याकाळी 8 मी बिझी आहे. अजित गांधी सर म्हणतात मी थोडंसं काम कमी केलं, मला आता पेशंटला मिळत नाही. आणि बाकीच्या हॉस्पिटलला द्यायला पेशंट तयार नसतो. मग कुठनं करायचं इन्व्हिजिओ ॲम्निओसेंटेसिस? आणि पंढरपुरात सिव्हिल सर्जन काय आम्हाला परवानगी देत नाहीत. म्हणजे ॲम्निओसेंटेसिस होत नाही, अवेलेबल नाही, आणि ज्याच्याशिवाय उत्तर मिळणार नाही अशी नुसतीच तपासणी कशाला करायची डबल मार्करची? आता ॲक्युरसी डिटेरिओरेट्स इफ सॅम्पल इज नॉट प्रोसेस्ड इमिजिएटली. दबडे सर सांगतात आला बाबा 11 to 14 वीक्सचा पेशंट आला आहे. मॅडमनं सांगतात मॅडम बघा तो 11 to 13 वीक्सचा पेशंट आला आहे. मॅडम सांगतात सिस्टर ह्या पेशंटचा डबल मार्कर पाठवा. मग सिस्टर लॅबमध्ये फोन करत, अरे सिद्धू ते डबल मार्कर सॅम्पल न्यायचं बरं का. सिद्धू म्हणतो आता 4 वाजले माझी ड्युटी संपली मॅडम, तो दुसरा रेवन येईल, तो 5 वाजता सॅम्पल घेऊन जाईल. मग तो 5 वाजता सॅम्पल घेऊन जातो, तोपर्यंत सॅम्पल कुठं रस्त्यात राहतं माहीत नाही. मग तो आल्यावर म्हणतो अहो मॅडम पण ते तुमच्या हाऊसमननी बाकीचे लिहिलं नाही गो, पेशंटचं वय किती, लग्न कधी झालं, किती लेकरं झाली आहेत, किती मिळत, ते भरलंच नाही फॉर्म, ते राहिलं तसंच. त्याशिवाय ते उत्तर देत नाही ते लोक पुढचे. मग ते कसं तरी भरलं आणि नेमकं लक्षात की शनिवार झालं ना, आजची कुरिअरची गाडी गेली, मग ते सॅम्पल मुंबईला पोचायला वाजता सोमवार होतो, कारण ते काय क्लिनिशियनसारखे रविवारी उपलब्ध नसतात. मग तोपर्यंत ते बीटा-HCG लेवल वर जाते आणि चुकीचा रिपोर्ट येतो. मग जो रिपोर्ट उशीर झाल्यामुळे चुकीचा येणार, तो आधीच इंटरप्रिट करायला किती अवघड आहे आणि नंतर परत कसं इंटरप्रिट करणार. बरं, सोलापूरच्या लेवल इंटरप्रिटेशन अवघड होतं. कुरिअर सर्व्हिस दिसताना अशी छान दिसते, पण ब्लड सॅम्पलच्या बाबतीत बरीच अडचणीच ठरते. मग आता फॉक्सी GCPR गाईडलाईन्स काय म्हणतं, रुटीन अँटीनेटल केअर फॉर हेल्दी प्रेग्नेंट वुमन जे आहे त्याच्यामध्ये कुठंही डबल मार्करचा उल्लेख नाही. बेसिक इसेन्शियल्स केअर रिकमेंडेड फॉर ऑल प्रेग्नंट वुमन डज नॉट इन्क्लूड डबल मार्कर. हां, ॲडिशनल मार्कर जे आहे त्याच्यामध्ये त्यांनी म्हटलं की ॲडिशनल केअर अँड इन्व्हेस्टिगेशन्स टू बी प्रेफरेबली ऑफर्ड इफ अवेलेबल फॉर रुटीन अँटीनेटल केअर फॉर नॉर्मल हेल्दी वुमन. मग त्याच्यामध्ये डाऊन सिंड्रोमसाठी सुद्धा त्यांनी आधी NT स्कॅन सांगितला आहे, आणि नंतर मग डबल मार्कर सांगितलेलं आहे. आता डबल मार्कर टेस्ट आपण ज्यावेळेस पेशंटला सांगतो की रक्ताच्या तपासण्या करायच्यात, एकतर पहिल्या व्हिजिटला आल्या रुटीन स्क्रीनिंग करून 2 तास थांबून डिप्सी टेस्ट करून ते वैतागलेले असते. आता आयुष्यात परत कधीही रक्ताची तपासणी करणार नाही असं पेशंट पण करतो, कारण एकतर त्याला जरी पुस्तकात रेकमेंड केलं की पहिल्या व्हिजिटला तुम्ही डिप्सी स्क्रीनिंग करा शुगरसाठी, उलटी होत असते, मळमळ होत असते, नवरा वैतागला असतो, सासू वैतागले असते, मग ते साखरेची पुडी पहिल्या देतात, त्यांनी परत ती 2दा उलटी करते, मग उद्या परत साखर पिऊन करा म्हणतात. एवढं सगळं झाल्यावर 12 to 14 वीक्सला परत एकदा रक्ताची तपासणी नको बाई म्हणते ते, आणि त्याला परत 1500 रुपये वेगळं लागणार म्हटलं तर नकोच अजिबात म्हणते. मग तुम्ही किती तपासण्या करायला लावणार, आधी म्हटलं सोनोग्राफी करा, ते NT काय येते त्यात कळेल म्हटलं, मग त्याच्यावर हे पण जोडायचं म्हणतात, तसंही होत नाही. मग NT NB कारण परत हे करून एवढं सगळं करून शक्यता सांगणार बरं का, हो का नाही सांगणारच नाही. आता मग अशी सांगितल्याप्रमाणे गव्हर्नमेंट फॅसिलिटी अवेलेबल नाही, सेम प्लेसला प्रोसेसिंग होत नाही, फॉल्ट रिडिंग्स येतात, डिटोरेशन ट्रान्झिटमध्ये होतं. अफोर्डेबिलिटी 1500 रुपये लागणार टेस्टला कमीत कमी, आणि त्याच्यामध्ये रिस्क सांगणार, हो की नाही सांगणार नाही. आता 1500 रुपये कुणाला परवडणार, फक्त या लाडक्या बहिणीला परवडणार, किंवा 1500 रुपये मिळाले की चला या महिन्यात 1500 रुपये लागेल पण NT स्कॅन करायचा, तोपर्यंत ती 14 वीक्सच्या पुढे निघून जाते, मग तोपर्यंत होत नाही NT डबल मार्कर. हां, आणि मध्येच ते लाडका भाऊजी 1500 रुपये ह्यात संपून टाकतो, मग ते 1500 रुपये कुठे राहणार. ॲक्सेसिबिलिटी मेट्रो बघा सांगितलं, ॲक्सेसिबिलिटी पंढरपूरहून डबल मार्करचं सॅम्पल जातं, पण ते तिथं पोचेपर्यंत त्याचं काय होतं. आणि लॅबवाले पण कसे असतात बघा, डबल मार्करचा रिपोर्ट देतात, त्याच्यावर तुम्हाला म्हणतात की NT स्कॅनचा रिपोर्ट पाठवा, पण ते हुशार असतात, त्यांना माहिती सुदेश दोशींना NT स्कॅन ते FMF ॲक्रेडिशन सेंटर नाही आहे. सुदेश दोशी NTची इमेज घेतात, पण ते त्यांची इमेज मागतच नाहीत, ते NT 1.5 एवढंच फक्त मागतात. पण खरंच तुम्हाला जर फर्स्ट ट्रायमिस्टर कंबाईन स्क्रीनिंग करायचं असेल, काही लॅब्स मागतात की तुमची जी NTची इमेज आहे ती बरोबर घेतलेली आहे का, NB खरंच दिसले का, आपलं 2 रेगा कुठल्या तरी दिसल्यामुळे NB त्याला लेबल करून रिकामे झाले आहेत, ते मिड सजाटेड पोझिशन. सकाळपासून अनेक विद्वान लोकांनी सांगितलं NT कसं करायचं, तशा पद्धतीने NT NB केलं असेल आणि त्यात डबल मार्कर घातलं तर मग त्याला उपयुक्तता आहे ना, त्याशिवाय नाही आहे. आता मग सांगितल्याप्रमाणे लिमिटेड टाईम फ्रेम 11 to 14 वीक्स. मग आमच्या घरी लग्न होतं त्यामुळे आम्ही काही येऊ शकलो नाही, आणि मग ते लग्नाला गेले 14 वीक्सच्या पुढं 15 वीक्सला येतात, मग डबल मार्कर करताच येत नाही, मग सगळ्यांना डबल मार्कर कसं सांगणार करून त्याचा काय उपयोग होणार. आता प्री टेस्ट काउन्सिलिंग खूप डिफिकल्ट असतं, कारण आपल्याला समजायला बराच वेळ जातो, आणि त्या पेशंटला ज्याची बौद्धिक पातळी या क्षेत्रातली कमी असते, त्याची बौद्धिक पातळी कमी असतं असं म्हणत नाही, खूप चांगली असते, पण या क्षेत्रात त्याचं अंडरस्टँडिंग खूप कमी असतं, आणि त्यात जो हुशार असेल तो गुगल करून त्याच्या डोक्याचा भुगा झालेला असतो, त्यामुळे तो आल्यानंतर परत प्री टेस्ट काउन्सिलिंग त्याला खूप अवघड जातं. आणि बऱ्याच वेळेला वैद्यकीय क्षेत्रात सुद्धा डबल मार्काच्या टेस्ट बाबतीत कन्फ्युजिंग असतं, ह्याचा अर्थ नक्की काय, आणि आपलं इंटरप्रिटेशन इतकं अवघड असतं. इन्फॉर्मेशन लिमिटेड मिळालं की बाबा रिस्क कॅल्क्युलेशन होणार आहे, असं होण्याची शक्यता जास्त आहे, असं होण्याची शक्यता कमी आहे. अरे होणार का नाही सांग ना, शक्यता जास्त शक्यता कमी काय सांगतो, जोपर्यंत होणार की नाही सांगत तोपर्यंत ते टेस्ट फायदा काय ना. आणि त्यातलं जे पटाव आणि एडवर्ड्स आहे ते असंही IUD होते, आत्तापासून वेगळा काय शोध लावला तुम्ही तेव्हा. आणि डाऊन्स जे आहे, डाऊन्स झाल्यानंतर का प्रत्येक डाऊन्स काय तुम्ही MTPच केली पाहिजे काय नाही, डाऊन्सचे लोक जगतात, चांगले जगतात. आता मध्यंतरी एक व्हिडिओ जातो का, डाऊन सिंड्रोमला एक व्यक्ती म्हणत होती की आम्हाला काही जगायचा अधिकार नाही का, तेव्हा डाऊन्स डिटेक्ट करून त्याला प्रत्यक्ष तुम्ही MTP प्रमोट करायला काही गरज नाही आहे ना. आता इंटरप्रिटेशन कसं असतं बघा, आपल्या सोलापुरात कसं होतं, एक छोटासा विनोद सांगतो, वेळ आहे म्हणून. नुकतंच ते डोमिनोज पिझ्झा उघडलं होतं, मग आपल्या 22मधल्या एका माणसाने फोन केला, डोमिनोज पिझ्झा मागवला वगैरे, पिझ्झा उघडला, मग तिने फोन केला, अहो डोमिनोज तुम्ही कसला पिझ्झा पाठवले म्हणे, काय त्यात टमाटर नाही, चीज नाही, काय नाही, नुसती चपाती पाठवलं का. मग त्याच्या डोमिनोजवाला आपला हा म्हणतो येस सर, हो सर, काय झालं, काय अडचण आहे तुमची, काय नाही. मग नंतर हे सगळं म्हणतो, म्हटलं कुठनं बोलता तुम्ही? आणि मी बाळवेसमधनं बोलतोय. बाळवेसमधनं बोलता नाही, बरोबर आहे, तुम्ही ते पाकिट पालतं उघडलं, सरळ उघडा की, गप चहा चपाती खायचं, कशाला पिझ्झाच्या मागं लागायचं. तसे डबल मार्करच्या मागे लागण्यापेक्षा आपल्याला जे कळतंय ते आपण करावं. चहा चपाती खाल्लेली सांगली, कशाला पिझ्झा खायचा आपण. इंटरप्रिटेशन अगेन, कन्फ्युजिंग टर्म्स, हाय रिस्क, लो रिस्क, इंटरमिडिएट रिस्क. बरं, आता इंटरमिडिएट रिस्कचे पण काही लोक म्हणतात 1 in 100 इंटरमिडिएट रिस्क, 1 in 250 इंटरमिडिएट रिस्क, काही लोक म्हणतात 1 in 500 इंटरमिडिएट रिस्क. त्या लॅबचा वर्कलोड किती कमी जास्त किंवा त्यांना लोड किती कमी जास्त करायचा याच्यावरती इंटरमिडिएट रिस्क कमी जास्त होत राहते. बरं, 1 in 100 आपण ज्यावेळेस सांगतो की तुमच्या बेबी हाय रिस्क आहे, तुमचं डबल मार्कर टेस्ट पॉझिटिव्ह आली, त्या पेशंटच्या डोक्यात हे पटकन शिरतच नाही की 100 फक्त एका बाळाला असं होणार आहे, बाकीची 99 बाळं चांगली असणार आहेत. तो म्हणतो नाही नाही, ते डबल मार्कर टेस्ट तुम्ही एवढी भारीतली केली, ती 1500 रुपयाची टेस्ट, म्हणजे ते भारी म्हणजे 100% बरोबरच असणार, ते आमचं बाळ तुम्ही खाली करून टाका म्हणून. सो अननेसेसरी टर्मिनेशन अनफॉर्च्युनेटली दबडे सरांनी पण बघितले आहेत, आम्ही पण बघितलं की फक्त डबल मार्कर पॉझिटिव्ह म्हणून एक 10 वर्षापूर्वी अननेसेसरी टर्मिनेशनसुद्धा झालेली आहेत. आता पॉझिटिव्ह तर मगाशी मी म्हटल्याप्रमाणे ॲम्निओसेंटेसिस करा, पण ते आता अवेलेबल नसते, त्याच्या अडचण येतात. मग डबल मार्करपेक्षा सुपिरियर टेस्ट आहेत. आता ठीक आहे, FMF ॲक्रेडिशन जरी नसलं तरीसुद्धा अल्ट्रासाऊंडची चांगली चांगली मशीन येत आहेत. 2-3-4 कंपन्यांनी आजची कॉन्फरन्स स्पॉन्सर केली, त्यांचं एखादं मशीन घेऊयात, त्यातनं NT करायला शिकूयात. आपले अजित पाटील सरांना शिक्षक आहेत जे आपल्याला NT कसं करायचं, NB कसं करायचं शिकवतील, ते शिकूयात. त्यातनं आपण डाऊनची रिस्क किंवा पुढची रिस्क कॅल्क्युलेट करूयात. आणि फक्त डबल मार्कवर कशाला डिपेंडंट राहायचं ना. NT NB हे ऑब्स्टेटिशियनचा आपला प्रांत आहे, आपल्या मैदानात बॉल असू देत ना. आपण डबल मार्कर देणार, कंपनीकडे देणार, मल्टी स्पेशल कंपनी, कुठली तरी मल्टी कॉर्पोरेट कंपनी, मल्टीनॅशनल कंपनी पैसे कमवणार, त्यातनं खरं खोटं आपल्याला सांगणार नाही. आपल्या ताटात आपल्यासमोर होता, दुसरीकडनं कशाला आणायचं. त्यामुळे आपण NT NBवर जास्त डिपेंडंट राहूयात, डबल मार्करवर नको. करायचं असेल तर सुपिरियर टेस्ट मगाशी ज्ञानदेव सरांनी सांगितलं की NIPS इज 100% फॉर डाऊन सिंड्रोम, तशा पद्धतीची सुपिरियर टेस्ट करूयात. हां, डबल मार्करची युटिलिटी आहे. डबल मार्कर फॉर ऑल याला माझा विरोध आहे, डबल मार्करला विरोध नाही. इन्शुरन्सचा पेशंट आहे, त्याला काय फरक पडत नाही, खिशातनं जात नाही, त्याच्या खिशातनं जात नाही, माझ्या खिशातनं जात नाही, इन्शुरन्स कंपनी पळते, करून टाका. हॉस्पिटलचं रेव्हेन्यू वाढवायचं आहे, नवीन हॉस्पिटल बांधलं असेल, सुदैवानं मला लोन नाही घ्यावं लागलं, पण मला लोन असतं तर डबल मार्कर करायचा नक्की विचार करावा लागला असता. विदाउट लोन मग हॉस्पिटलमध्ये डबल मार्करचा विचार करत नाही. हॉस्पिटल वॉन्ट्स टू बोस्ट ऑफ प्रोव्हाइडिंग समथिंग एक्स्ट्रा, जसं मग सांगितलं दबडे सरांनी. मला सांगायचं अग्रज हॉस्पिटल डबल मार्कर पण आहे, तुम्ही या माझ्याकडं, त्यावेळेस डबल मार्कर करूयात. नाही तर तसे पोटभर पेशंट असले पण डबल मार्कर नाही करावं लागत. अँड टू सॅटिस्फाय दोज पेशंट्स, माझ्या पुण्याच्या मैत्रिणीने डबल मार्कर केलं तर बरं का, माझ्या मुंबईच्या मैत्रिणी केलं तर तुम्ही का करत नाही डॉक्टर, अशा लोकांना डबल मार्कर करायला काही हरकत नाही. बट डबल मार्कर इज नॉट फॉर all, only in selected cases who are high risk, calculated on basis of not only age नुसता हा क्रायटेरिया कधीच धरणार नाही, त्याच्यावर हिस्ट्री आहे, फिजिकल फाइंडिंग्स आहेत, मॅटर्नल हिस्ट्री आहे, ऑब्स्टेटिक हिस्ट्री आहे, अल्ट्रासाऊंड फाइंडिंग्स आहेत, NT NB DV TR स्कॅन, हे स्कॅन्स आहेत. आणि हे करून म्हणून डबल मार्कर फॉर ऑल अजिबात नाही, डबल मार्कर फक्त सिलेक्टेड पेशंट्समध्ये करावं. एवढं करून मी थांबतो. काय चुकलं आपलं माफ करा, तुम्ही मला गुरुस्थानी आहात.
थँक्यू डॉक्टर दोशी. It was lovely discussion. We want to know how many people are doing double marker.
Sir, yes. Let's take an opinion of the hall. How many of you do NT for all your routine patients is what Rohini Deshpande madam is asking.
Routine NT
and then followed by double marker, the entire
double marker
screening.
test. So quite a few are doing double marker plus NT,
Yes,
right?
yes ma'am.
Is best done as combined testing.
Combined test,
Dr.
we all are
Combined
doing.
testing.
Dr. Ajit Patil is not raising his hand.
Sensitivity increases when you do a combined testing.
Yeah, it's actually statistically it is quite proved that when you use all these markers plus biochemical test, the sensitivity is going to increase of your screening. And screening is for all low risk population. It's
Yes.
not like high risk. So the purpose of screening is to pick up those patients who probably you would not have detected. And as you rightly said, Dr. Doshi, that counseling of the patient plays a very important role. Because if the report comes something like ambiguous or maybe intermediate risk, it is sometimes difficult to explain to the patient, and it may warrant certain more investigations which will be more expensive. So it becomes quite traumatic for the patients, mentally, physically, financially. So these are the pros and cons of this. But unfortunately or fortunately, we are now in such a situation that, people themselves are asking, like, तुम्ही डबल मार्कर टेस्ट करणार आहे ना, आमची एंट्री करता का? म्हणजे इट्स लाईक पेशंट्स आर ऑलरेडी नाव एज्युकेटेड अँड दे ऑल्सो गो थ्रू द लॉट ऑफ information on social medias. So I think we have to stick to certain protocols or maybe having a certain unanimous decision की अशा प्रकाराने करायचं. आता यू सेड की फॉक्सीमध्ये असं लिहिलेलं नाही गाईडलाईन्स, पण ॲडिशनल. And another thing is we have to be very, very sensitive for the medico-legal things.
Yes.
Because if we miss out something, suppose patient is not affording, that's not the thing. You have to tell them what are the things available for them. If they want to do it or not do it, and you must record if they have denied the test, which we often do. Like not everybody will agree to what you say. And you have to explain to them that these are the things which are available to you. Like even NIPT, these we have to give them information. Whether it costs 10,000, 11,000, doesn't matter, because for them the pregnancy is only for one time. For us, we are seeing so many patients. So it all depends on how our approach, our counseling, and post-test counseling as well, and then follow them up. And another thing is in double marker nowadays, they also give a prediction of preeclampsia, which usually, it helps us, like what we have done on ultrasound by taking the bilateral uterine arteries as well as mean PI, and the risk which is quoted on double markers. Sometimes it can be, it may complement with each other, and we can re-emphasize or we can put them on aspirin. And nowadays they are also giving the risk of fetal macrosomia, which I really don't understand whether it is something which really adds or what is the sensitivity of that. Dr. Ajit, you can tell us about that?
Hello.
As far as growth restriction is concerned, to complete this combined
Okay.
screening is a very good tool to understand growth restrictions. For macrosoma, it's not really that helpful.
Yeah, it's not very sensitive.
Not that.
But patients, they report better than us sometimes.
Yes.
That is what I have, sometimes we may miss something, but they will tell, doctor, what is this? And sometimes you have missed it also. So I think we have to be very, very careful. Yeah, in Lilac people, they are reporting that.
ॲक्च्युली ह्याला म्हणजे सुदेश सरांनी जो लाडकी बहीण आणि लाडक्या भावांचा उल्लेख केला, म्हणजे तर त्याचं उत्तर हे आहे की जसं तिथे शासनाने इथं लाडक्या बहिणींना 1500चं सहाय्य दिलं आहे, तसं गोवा सरकारने हे सगळं फ्री ऑफ कॉस्ट केलेलं आहे. आणि गोवा इज द फर्स्ट स्टेट इन कंट्री which has taken over the screening during pregnancy is free of cost. So Goa offers entire complete this combined screening free of cost to their population. Of course गोवा छोटं राज्य आहे, त्यामुळे त्यांना हे करणं शक्य आहे. कदाचित गोव्याची इकॉनॉमी पण चांगली असावी, त्यामुळे पण हे शक्य आहे. महाराष्ट्रासारख्या मोठ्या स्टेटला हे कदाचित शक्य नाही, पण कदाचित अशी पावलं उचलते गरज पडू शकेल.
Also, newborn screening. Goa is the first
Goa is
place
newborn screening.
where they took up this project free of cost. Newborn screening.
Yes. So thank you very much, Dr. Sudesh and Dr. Rajiv Dabade, for enlightening us, and it was quite insightful. Thank you very much.
Thank you, ma'am. Our next debate is on os tightening for all twin gestations. I request Dr. Anuradha madam to introduce Dr. Vijay sir and Dr. Lalita ma'am to introduce Dr. Meenal Chidgupkar so that we can start with the debate.
Dr. Vijay Pawar sir is MD DNB. He is an associate professor of VM Medical College Solapur and a unit in charge. He is an ex-clinical associate at Regenesis Center for ART endoscopy and fetal medicine. He has done a fellowship in ART in 2016 and fellow of Minimal Access Surgery of India in 2015. Currently sir is a consultant at SIMS Fertility Center, Solapur. Over to you, sir.
welcome Dr. Vijay Pawar.
Lalita ma'am, can you introduce Dr. Meenal also so that we can then continuously have the debate together?
Thank you, ma'am. Dr. Meenal Chidgupkar, madam, MBBS, DNB, FCPS, DJO, MNMS, OBGY, Senior Infertility and IVF Specialist at Apollo Fertility Solapur, 12 years experience in infertility and laparoscopy, DNB from LTMC Sion Hospital, Mumbai, Diploma in Infertility and Laparoscopy from Care University, Germany, Fellowship in Reproductive Medicine and Advanced Laparoscopy from NHS, England.
Good afternoon, respected teachers, chairperson, my dear colleagues, and hi Meenal. The first slide I would like to put here, especially for Meenal and all as we practice, is first do no harm. So whatever I am going to talk about, don't take it personally. So we have Dr. Meenal. She has beauty with brains. We all know she has a lot of brains as well as beauty. And the organizers thought that they will try to have a fight between a beauty and a beast. So this is what I think the organizers wanted to have post-lunch session so that everybody gets up, nobody sleeps. So my job is to see that all of you are awake. There will be a slight amount of humor and in this. And this is what I am going to try. I am going to make the beauty versus beast, what the organizers have thought, to make the beauty with the beast. So I'll see that Meenal is on my side rather than being on the opposite side by the end of this talk. So we know that Meenal has a lot of beauty and brain, but the side that she has taken, I don't know whether she has become insane. So this is unknown quote, insanity, doing the same thing over and over again and expecting different results. So in the conferences, lot of conferences, we see same topic again and again, same thing, cervical length, there is progesterone, there is funneling, there is V-shaped, U-shape. We all are talking about this is, I think, I'll show you some slides which are since 2003. I have joined PG in 2000. And since that time, this is the same thing happening. And last 25 years, we are still debating on the same thing over and again. I don't know where is the debate. Debate is so clear cut, you can see in front of you. In twin pregnancy, we have such a 50% risk of preterm labor. And in singleton pregnancy, it is 6% risk. So you can't compare the data of singleton pregnancies and apply it in twin pregnancies. So, are we going somewhere doing something wrong, especially Meenal? You should see that we should not be insane. I know that you are not insane. You have a lot of beauty and brain. So, coming to this new thing, I would like to tell you, this is something which is called as first principle thinking. I don't know if you know about this. This is something which is used in problem solving. The problem that is given to is that twins are having preterm labor. So how to solve this problem? You have to break down the complex issue into the basic parts and then build it from there. So this is the basic concept which all the legends have used from the historic past. If you use this principle, especially in this problem also, you will come to know that what is the question, you have whether to stitch for all twins. Create new knowledge. So we have some knowledge from our experience from the past and we have to apply it. Now when will we apply? We will apply only when the Europeans, American will apply. Then they will tell us, no, this is the way you have to go ahead. Cervical length screening has to be done. We'll go for Fetal Medicine Foundation. We have Ajit Patil sir here who can train us, but still we'll look for Fetal Medicine Foundation. We want certificate from Europe. We don't want certificate from India. Meenal also went for IVF to abroad for certification. She didn't take the training here. In spite of Dabade sir being here, Milind Patil sir being here, but still she wanted to go abroad. I have not gone abroad. I have done here. So I believe in Sabka Saath, Sabka Vikas, Sabke Saath. Understood? So discard the old things. same thing again and again we are doing, and we all believe what happens, सगळं तेच करायचं and we expect different results. So very important. Reverse engineering. We know the best country using reverse engineering is China. They are even the advanced instrumentations the US people are not ready to give to others, because if it lands in Chinese hand, they will do reverse engineering and build it within 3 or 4 years. That is the level of reverse engineering what China has done. We are also should follow something like that. So don't see what is happening around us and just build on that, and you try it and do it. It will happen. So we all know Sir Vittal Narayan Shirodkar sir, the legend. He has used first principle thinking. This is Meenal Aristotle. If you remember, I am telling you from the past, he has used first principle thinking. This one I am sure you know of this person, Elon Musk. He is the pioneer in first principle thinking, and now he is into, you can see he has gone into the Trump government, and he is going to, in the next 4 years, he is going to change America completely. It is a disruption that is going to happen in the way the America works, and this is because of this person, Elon Musk. So again, what I am trying to do is just give you what are the principles, and then I will give you some points. Then you, Meenal, apply these points and try to do some first principle thinking after taking all these people into consideration. Okay, so this is something. Who are those you know that have done some things in the past? In Stitch we have Shirodkar sir, who has done this in the past. We have so many lab surgeons who are doing laparoscopic encerclages, abdominal cerclages by Benson, Durfee is done. We have McDonald stitch. I hope all of the gynecologists here know how to do McDonald stitch. They may not be knowing NT, how to do NT, half of them. But all of them 100% know how to do McDonald stitch. It is one of the bread and butter. Am I correct, audience? Yes, so all of them know it's such a simple, easy procedure. Morning you admit, evening you send them home. What is the problem? You can do it. What are the underlying principles of doing this surgery? You do the cervical stitch, there will be strengthening of the cervix. There will be no dilatation and effacement of the cervix. It will prevent the mucus plug from dismantling. So it will prevent your ascending tract infection. So it will prevent the cause of preterm labor, that is chorioamnitis. So simple. It is so समोर दिसते पण करायचं नाही. का? कारण अजून वेस्टर्न डेटा आलेला नाही. Now I will tell you what western data has come later on. So this is a complex. In India we try to make things complex, like the previous debate. हे करो की नको, ते करो की नको, ह्याच्याने काय होईल, त्याच्याने काय होईल. So any test that has to be has no further action. If the patient is not going to take any action on that report, like PAPE, your report comes positive marker, and then you don't know, the patient says I don't want to do further test. NIPT पैसे नाही, 9-10,000 रुपये नाही आहेत, amniocentesis शक्यच नाही, करतच नाही, मग ही टेस्ट कशाला केली. So it is like that. So same is with, we make it more complex. It is so simple. समोर दिसतंय की preterm labor होणार आहे twins मध्ये. So you put a stitch, so simple. Or you are putting progesterone also we are giving. Meenal, this is a horse, not a donkey. Okay, so I hope you understand. So look at other things that work currently on the same principle. That is, we are actually using this cervical stitch in patients who have short cervix. Dr. Ajit Patil sir has explained. He has now given a online software also which you can use and put, but that will be used only when you will have those cervical length markers. Now coming back to the basics, you know about this book. I hope you must have read in your UG and PG also you must have read. This is that Dr. DC Datta textbook, and there is a chapter on multifetal pregnancy which is chapter number 17. Since last so many years it is the same number chapter. The preterm labor, if you see the incidence, it is around 50%. So it is such an high incidence compared to the singleton pregnancy, which is only 6%. So you can't apply the same logistics principles of screening everything in singleton into twin pregnancy, or for that matter multiple pregnancy. And you being an IVF specialist, I am 100% sure all your twin pregnancies you are putting a stitch. You are practicing what you are not preaching. Okay, so you are going to preach here that you will not put stitch, but in your practice you will put stitch. Now coming to this recent 2023 AGOG articles, this is what is given in the articles about the cervical length in singleton pregnancy. So if you see the length less than 2.5 centimeters, the incidence of preterm birth is 23% in singleton pregnancies. Same, they have put different methods, what is the cervical length in the third trimester and what is the incidence of preterm labor. So, cervical changes in twin pregnancy, just read the conclusions. So, here what the conclusion says, in twin pregnancies, preterm cervical shortening is more rapid. So, more rapid म्हणजे काय fast होते. आज screen केलं तुम्ही routinely you are asking to screen every 2 weekly. So, you don't have time in twins for 2 weeks. By the time the cervix now is 4 centimeters, after 2 weeks it will be 1.5 centimeter or maybe 1 centimeter. So, you have already missed the bus. So, you will have to, if you want to screen, then you have to screen every 3rd day, 4th day, maybe daily also. Every day patient will come, you will start doing TVS. No, it is not possible, impossible thing. This you already know. This is T, Y, V, U. This you are going to see in the ultrasound. So, again coming to preterm labor, remember this slide. Singleton 6%, twins 50% incidence of preterm labor. I am repeating same thing again and again so that it gets into your head. You know, you'll never forget once you go out from here. You'll remember this slide. 50%. Okay, so what I am trying to see the outcome. You are all going to practice on outcome. And once you know you have to develop different kinds of habits. So there will be something called as belief-based habits, system-based habits, and outcome-based habits. You are following outcome-based habits. Means whatever the cervical length will come. If it is short, then I will put the stitch and then I will debate. Then the patient, and if it fails, then the patient comes to you and asks, Doctor, तुम्ही तर स्टिच घेतले 25-30 घेतले माझ्याकडनं आता परत द्या आणि हे पोलीस केस पण फॉलो करा. So that is outcome based habits. So first change your belief that whatever is given in the Western literature is only true. You have some experience, you have brain, use your experience. We have seen twins pregnancies, we all put stitch. Then why you are telling on the stage here that you are not going to put stitch? So change your identity, be real to yourself. So this I already told you, cervical cerclage is a surgical technique applied to strengthen the weak cervix, maintain its length and preserve the mucus plug at the cervical opening, thus protecting against the ascending infection. Remember this lifelong and put stitch for all twins. Okay, so the type of encerclages I think you already know. If you don't know, you can come, we will teach you. We are in the institute, we have vaginal McDonald's surgery. Okay, then we also do modified Chidgupkar surgery. Abdominal cerclages are done and laparoscopic cerclages also we are doing very well in our institute. Now, this is the study that everybody quotes in asymptomatic twin pregnancy for cervical shortening dilatation. So it's a 12-year data. If you go through the data again, the cervical encerclage appears to prolong the gestational age at the delivery and interval time. So even if it doesn't prevent, it may not prevent preterm labor, it will prevent extreme prematurity. So if the patient was supposed to deliver at 28, she may deliver at 32 weeks, 33 weeks. So you will at least buy around 3 to 4 weeks of time. So this is a study. Now this is the same thing, you have to understand the principle of first thinking. You already have this knowledge in asymptomatic twins, you have the cervical length is less. Now why don't you apply for all patients then? Because the incidence is 50% of preterm labor, it is not 6% like in singleton pregnancy. Common sense. No, anybody who doesn't have brain will also agree to this. Am I true? All of you have brains, no? So I think you will agree with me. Thank you. So you never know how close you are. Never give up on your dreams. So this is what Napoleon Hill has already said. सगळं करायचं ट्विन प्रेग्नन्सी करायची IVF करायचं आणि नंतर ते जवळ स्टिच न घालता अबॉर्ट करून टाकायचं और पेशंट गेट्स अबॉर्टेड और गोज इनटू द NICU, pays a bill of around 8-10 lakhs rupees per baby and then they'll come to you again, doctor सगळं असं झालं तसं झालं, and God forbid again that baby becomes with cerebral palsy, and lifelong you have to sit with the child. So this is what is happening. You are going till the cervical stitch and then you are returning back. So remember this slide, okay? If you want, I'll send this presentation to you. You can keep it with yourself. You can keep it in your consulting. Whenever you get a twin patient, you see this slide. And you are going to wait for this. You know this, what is the dam? Dam बांधायचा अर्धवट सोडून द्यायचा, or you don't strengthen the dam, and this is going to happen. And असं झाल्यानंतर then you want to salvage. Then everybody will start running around to prevent further damage. So once the gates are open, no way it is going to stop, and the ultimate morbidity and mortality is going to happen. So every man is what is because of the dominating thoughts which he permits to occupy his mind. So what you think in your mind, you start believing, and I am sure by the end of my presentation, you must have changed your mind, and maybe I don't think you will come and debate with me on this topic again. And it is time to slide लाव ना पुढचं. So he is also agreed that so it is time for change, Meenal. I think you have to be on my side, the beauty with the beast on my side rather than in the opposite side. I thank you for your patient hearing.
Thank you, Dr. Vijay. Now the ball is in your court, Meenal.
Respected moderators and all my teachers and my colleague, today my topic is no cervical stitch, no routine cervical cerclage in twin gestation. And I really respect Dr. Vijay Pawar sir, he is my senior. I will definitely come to him and learn the difficult cervical cerclages such as Shirodkar cerclage. I know he does the best. But there are few things we have to go evidence-based. We cannot just say something what we feel, so we have to go through this topic in a very evidence-based manner. And still I want to tell, because this is the era of artificial intelligence, just type this question and see what artificial intelligence is saying about this. It is saying no cervical stitch for all twins. So good afternoon, ladies and gentlemen. Let's dive into the question of whether every twin gestation needs a routine cervical cerclage. Now before we jump into the science, let me clarify, twins are double the joy, but not double the stitches or double the interventions. Let's talk about twin gestation and routine cervical cerclage. Now, twins are a double blessing, but should every set of twins comes with pre-ordered stitch? If we do that, we would run out our suture materials faster than we run out of baby names. So let's unpack the science and evidence and little bit of humor to sew up this debate. So should we routinely stitch every twin gestation? Twins are double the joy, but do they need double the intervention? Yeah, I know, and it is a very important slide. Dr. Vijay sir has elaborated multiple times that incidence of preterm birth is higher in twin gestation than singleton pregnancy. It is approximately 50%, and almost all preterm births, 18 to 25% is because of twin or higher multiple gestations. Now this important slide emphasizes that twins has 50% of preterm birth. Now whatever preterm birth and multiple gestation evidences which we have come through, and cerclage has been an effective in preventing preterm birth in 3 populations based on the randomized controlled trials. So data is like first history indicated, ultrasound indicated, and third is physical examination indicated. But all this is for singleton pregnancies. There is no real intervention to prevent preterm birth in multiple gestations, and not much data regarding cervical stitch association with multiple gestations. Now, as we all know, and even Vijay Pawar sir is into a reputed like college where we tell our students to believe this evidence-based medicine, where what comes at the helm of it is meta-analysis, and which is a filtered and appraised data. Now, sir is telling us to go to the like baseline of this pyramid, saying believe this background information, expert opinion. So it is our like audience to decide what exactly to take. We have to follow the filtered meta-analysis data which is happening worldwide and what they are suggesting. Yes, when we were in UG, we had level 1, level 2, level 3 evidences, and what sir is telling is level 3 evidence right now. And after that, the grade system came, and the data which he is presenting is a very low quality evidence. Now, what is evidence-based guidelines? What do the guidelines say? ACOG 2021, no routine cerclage unless cervix is less than 25 millimeters before 24 weeks, history of recurrent second trimester loss. RCOG 2019 says cerclage reserved for high-risk cases. Takeaway is routine cerclage is not a default strategy for all twins. So key studies, there are prolonged trial, which is 2019. The outcome says no significant reduction in preterm births in twins with routine cerclage. CIPRAC trial where risk identified is increased, chorioamnionitis and preterm labor with unnecessary cerclage. So conclusion is evidence does not support blanket cerclage in twins. Now we have to go to research and the meta-analysis, where these are all the data beyond 2016, the 2018, the cerclage for women with twin pregnancies, a systematic review and meta-analysis, where less than 15 millimeter of cervical length, it has been beneficial, and further high quality studies are needed to confirm the findings. And the updated systemic review and the meta-analysis, which is published in 2021, which states the safety and effectiveness of cervical cerclage on maternal and neonatal outcomes in twin pregnancies remain inconsistent. However, for twin pregnancies, for a cervical length less than 15 millimeter, cervical cerclage was associated with significant reduction in preterm birth. Now, there are various studies where effectiveness of cerclage in twin pregnancies with short cervix, then effectiveness of cervical cerclage in twin pregnancies, where the obtained data suggests that cervical cerclage inserted based on physical examination or ultrasound examination may significantly extend pregnancy duration and improve neonatal outcomes. The same study which Dr. Vijay sir has mentioned about the use of cervical cerclage in asymptomatic twin, but here it has a cervical dilatation and shortening, and there we are giving this cerclage as a method, and that has increased the gestational period also. Now there is a Korean study also, a very recent study, 2023. They say if you do unnecessary cerclage, there are problems associated with it. So the risk of routine cerclage is there. The potential complications such as infection, premature rupture of membranes, cervical trauma and uterine stimulation, and stitching every twin pregnancy is like over tightening your shoelaces before a marathon. And I just want to ask everyone that we have to be very sure we should not have any complication, then why not cesarean for all? This is the same way I wanted to defend cesarean should not be for all. The same way this cervical stitch should not be for all twin gestations. what are the alternative to routine cerclage, the safer approaches which are available, such as vaginal progesterone, which has a proven effectiveness in short cervix, close monitoring, and definitely, as Dr. Patil sir has said, the serial ultrasound for cervical length, and find out if there is any problem. We are there for the patient to give the cervical stitch. The tailored intervention and individualized care avoids unnecessary risks. So routine cerclage for twins, hospitals would run out of suture materials and obstetricians might start crocheting themselves. So it is very important to understand this evidence-based medicine, and which plays a critical role in modern healthcare by integrating the best available research evidences with clinical expertise and patient values to guide decision making. So we have to see the filtered data, the meta-analysis, and understand the further things. The countering the routine arguments, I would say, erring on the side of caution, not when it increases harm. All twins are at risk, risk varies. One size fits for all is outdated. So you can't wear a helmet for every rain cloud, and the same with the unnecessary cerclage. We cannot wear helmet and walk because there can be a chance of accident. So we have to be aware of what is to be done for our patients too. So my take home message is, like this, the routine cervical cerclage in twins is not backed by robust evidence. Risk overweighs benefits without clear indications. Trust science and not superstition. So let's save the stitches for those who truly need them. So twins share everything: toys, clothes, and sometimes even attention. But they don't have to share a routine cerclage unless it is absolutely necessary. So thank you everyone. This is from my side. I hope from the audience they understand that I practice infertility, and as Dr. Vijay sir said, yes, I'm giving cervical cerclage for all infertility patients. But for the normal patients and for the IUI pregnant patients and the patients who absolutely don't have the previous like complications or previous histories of preterm deliveries or short cervix, we need not have to give cervical stitch for all of them. Thank you.
Thank you, Meenal.
Thank you, Meenal.
Dr. Vijay, do you
Dr.
want?
Vijay, you want to say something? You can stay there. Meenal, you can also stay here.
Okay. I think in the concluding remarks, she agreed finally that she herself puts stitches for all patients. And just because you are doing infertility doesn't give you the reason that you will tell something here to the audience. It is like all the conferences. Everybody talks something else and practices something else. That is why, especially in infertility, we have always seen that. People will talk so many things, this protocol, that protocol. Ultimately, everybody will go into only antagonist protocol in IVF. So something like that, you are telling something on the stage that you should not put stitch for all twins, but in your patient, because your patients are special, you will give them special attention. Other patients ka kya karoge? Other thing is like, we are talking about cervical length. That's what I said, 2003. Even before, I think maybe I joined MBBS, these things is happening. But still it is not possible to practice till the grassroots level. Doshi sir is practicing in rural area. In the periphery, nobody does cervical length monitoring. If you are transvaginal scan, putting the probe in the vagina itself a big thing. So these are the practical things that we are having. We are talking in air-conditioned hotels here about things to be done. It is so impractical for every 2 weekly to come to OPD for scanning. When patients come to government hospitals you should come and sit in the government hospital and see. Doing routine antenatal sonography is a big thing. This form, that form, online upgradation, this inspection, that inspection. half the time you are filling forms. So people don't want to do it. That's why disruption technology, that is why I put Elon Musk picture. Why Elon Musk? Everybody admires him. Even when he took over Twitter, you remember everybody was shouting, and now he has changed the whole game in Twitter. He's changing spaces. He's talking about going to Mars. 5 years back, we were thinking he's a mad fellow who can go to Mars. But I am sure one day he will go to Mars. He will put man on the Mars because he is thinking differently. So that is what I am telling you. You have such a beauty, such a brain, but why you are thinking same insanity you are doing? That's what I was telling you. Don't do the same thing again and
Sir,
again.
can I ask
and
you one
expect the different
question
result.
for your twins, what you did?
That is what I am trying to tell you. We didn't put the stage. They delivered. Listen, they delivered at 35 weeks. What I mean to tell you here again is the same thing. The preterm labor may not be prevented. That means below 37 weeks they will deliver, but they will not deliver at 30. So if you put the stitch early, they will go to 32, 33. That is also fine. But if you have a delivery at 28 weeks, 27 weeks, 29 weeks, you know how the survival rate we have in Solapur. You ask the pediatricians in NICU and Ashwini, take home baby rate such a poor. So patients have to pay from the pocket. So much amount of money goes in NICU case. So stitch we all do. To put McDonald's, you can do it free, no problem.
So Meenal,
Money
are
is
you
not the
convinced
problem.
now?
Even with
Are you
progesterone, it
convinced?
is the same thing.
About what
Progesterone,
he
20 rupees capsule per capsule. You want to put 2 TDS, 3 days. That means 100 rupees per day for 3-4 months. No patients afford. Patients don't pay for iron calcium tablets. In the rural sector, it will be there in the private sector. I know we have patients who pay for the tablets, but in generalized, when you want to do the simplest procedure that we see all around, progesterone, cervical stitch, serial ultrasound monitoring, which is cheaper. I think it is
Okay, Dr.
and I am not saying that the stitch has to be taken without care, like you said about infection. You screen for infection, give antibiotic prophylaxis, do the vaginal swab, and then do the stitch.
Thank you, Dr. Vijay, and thank you, Dr. Meenal.
Thank
But
you.
let's take the poll of our audience.
Yeah.
Let's see what is all is.
But this is for all twins. This is not for infertility twins. I am again telling you. So for all
No,
twins,
nothing. Infertility twins are same. What is different?
no,
in that?
infertility is
They
a
are also
different
twins
thing.
pregnancy.
Yeah, but infertility is associated with the preterm. Then
That's what I am trying to tell you, doctor. 50% incidence of preterm labor.
No, Dr. Vijay, may I just ask you, at what gestation do you put the stitch? At what gestation? At what gestation do you put the stitch? And is it
I put the stitch. I put the stitch when Dr. Sumit Chamaria, my fetal medicine specialist, tells me he will do the anomaly scan. If he does the anomaly scans and says go ahead, I put the stitch after the anomaly scan.
okay? And so irrespective of the cervical length.
Madam, that's what I told you. When they have screened in the asymptomatic twins,
Yeah.
cervical length, the cervical length rapidly changes. So what we are doing, we are calling every 2 weekly for scan if you want to screen. But by the 2 weeks, the time will already go. If she has to dilate, she will dilate early. That is the point. And this is something which you have to change in your head first. Change the belief. Because there is no trial that has been done. Nobody has done this. The very fact that this topic or debate topic has been put in the conference for fetus, that means everybody is doing it, but they are not telling it on the board.
Yes, sir.
Yeah. Okay, Dr. Vijay. I think all
Thank
the people in the audience, let's raise the hands if they are doing for everyone in twin pregnancy. Yeah, there are very few hands.
Yes.
There.
We will go with Chidgupkar, ma'am. Not for generally, not for all twins.
Not for all.
Not for
twins.
all twins, ma'am. As madam said, it is okay for infertility patients, but I have seen many twins delivering full term, madam, 37, 38 weeks. And I
Madam,
think they
that's
have
what
not
I'm
taken progesterone.
because it is 50%. 50% are going to deliver term, 50 are going to go for
Thank you,
preterm.
But
chairpersons.
sir, anyway, even if you put a stitch for those patients, they will deliver
Thank you,
preterm, sir.
chairpersons.
Thank you.
The panelists have to go wind up the session. Thank you.
Thank
But
you.
I thank you, Dr. Vijay, and thank you, Dr. Meenal, for taking us through all this.
I request the
Twins.
chairpersons
Thank you.
Marda sir, Garad madam and Lalita ma'am to come on the stage. Dr. Milind Shah sir and Dr. Neeta ma'am, please accompany them. We want to first felicitate our moderators, Dr. Rohini Deshpande madam and Dr. Vidya Tirankar ma'am. Now we would like to invite our debaters, Dr. Rajiv Dabade sir, Dr. Sudesh Doshi sir. Dr. Vijay Pawar sir and Dr. Meenal, please come on the stage. We need to start the next session also. Thank you all four of you to keep us awake in the post-lunch session. I request Milind Shah sir and Ghate madam to felicitate our chairpersons. Our chairpersons, Dr. Lalita Swami madam, Dr. Lakshmikant Marda sir and Dr. Anuradha Garad ma'am. Thank you, everyone. We are now moving forward for the last session of this conference, that is the panel discussion on soft tissue markers on ultrasound.